Good evening, everyone. We apologize for the technical challenges we've had. Dr. Johnson and I think we're talking several slides behind this evening. So I think we have our slide set here. That was our pre-recorded presentation, and we're going to move to a live presentation. So you get even more cutting-edge information than in our recording. So Dr. Johnson, do you want to pick up here and talk about this example?
I can pick it up right here. This is, it's good to review these cases again anyway. This is, I was explaining before about the way we can measure when this disease starts. And what I'm showing here is a case example of somebody who we estimated that they began their journey with Alzheimer's disease about 23 years before they even knew they had this disease, before they had dementia. And that's pretty remarkable. In this case, this person was 51 years old. And now at age 74, they have lots of amyloid plaques and tangles in their brain based on these imaging scans. Let's go to the next slide. Alzheimer's doesn't occur by itself. Cerebral vascular disease is the most common co-occurring problem together with Alzheimer's. And if a person has both of these diseases, they may decline even faster and be more vulnerable to later decline in their life. And fortunately, there are some things we can do to improve our vascular health. And we will be talking about those a little bit later tonight. Let's go on to the next slide. The blood-based biomarkers are really extraordinary, and I'm going to turn this over to my colleague, Dr. Carlson, once again to pick this up from here. Go ahead, Dr. Carlson.
Thank you. And again, I think learning to work with technology, it'll help make our brains more agile. So hopefully we'll all learn from this experience and have a little sharper response to our next day's events. So again, with the blood-based biomarkers, the reason that we're so thrilled about the work that we're able to do in this is that even though we have these wonderful brain scans, the MRI scans and PET scans, what we really hope to do is to be able to bring this research into communities, into clinics across the state. So we don't want people to have to travel to Madison to get these highly specialized scans. So what blood-based biomarkers do are allows us to really bring this into the clinic, into community settings, so we can look and see what are these levels of amyloid and tau, these two key proteins that are associated with Alzheimer's, and other biomarkers too down the road. So again, we're really trying to help move it from these highly specialized tests, which are excellent, to trying to bring it to a blood test that's much more accessible to diverse populations. Next slide. Next slide. Thank you. Yes. So again, what we're also trying to do is to work with diverse communities and see what are some of the health and lifestyle factors that we know can help slow cognitive decline. And so our teams are working on a variety of factors. So working on how much exercise we get. Does exercise help protect our brain against these amyloid changes in the brain? Or sleep. Does sleep help us clear the amyloid, or at least help our thinking to be sharper by improving oxygen and improving other brain functions? What about our diet? We hear about the MIND diet, Mediterranean diet. So we're studying those factors too, and also proposing some interventional workshops and things to help people to make these lifestyle changes. We have studies looking at gut health, and as Dr. Johnson mentioned, blood vessel risk factor control. And then also an important area called social determinants of health, which was neglected previously, which really helps us to better understand how do different stressors, access to good medical care, educational opportunities, and issues of poverty, how do those factors affect our brain health in the long run? So we have studies like shown on the map on the right that show us areas that have less advantage or more advantage with these social determinants of health. So areas of poverty or low water supply, high rates of unemployment, those factors are being studied as well and been associated with either a lower risk or higher risk of developing cognitive decline. Next slide. Our program is also moving to try to target these medications directly at these various proteins that build up in the brain. So we've heard a lot about aducanumab, and we will be glad to answer questions about that. And while it's a mouthful, it's basically a therapy that's targeted against amyloid buildup in the brain. And so our program has a variety of studies. We have other anti-amyloid therapy studies right now for people who don't have any memory problems, who have amyloid buildup in their brain on PET scans. So we have other therapies that are being evaluated to see if that helps not only reduce the amyloid in the brain, but also if it helps the person and help them to function better. So we have studies looking at not only anti-amyloid therapy, but statin therapies, fish oil, therapies that look at gut health, exercise, and for people both with cognitive impairment and people without cognitive impairment as well. Next slide. And ultimately, we want to try to prevent the disease, delay the onset, but also trying to bring good medical care across the state and bring research opportunities to diverse communities. Our work is much better when we include people who will most benefit from the therapies that are offered. So persons who are at highest risk for developing Alzheimer's disease, that includes people from diverse communities, African American, Latinx communities, Native American communities. And so really trying to make sure that the studies that we conduct have good representation of the people who may be most likely to benefit from prevention. So with that, we'll turn it back over to, I think, our live moderation. So thank you.
Thank you very much, Cindy and Sterling. Thanks for adjusting on the fly as we work through some of the gremlins here tonight as well. We thank all of you, of course, for your patience with us. Next, we will hear from Dr. Carrie Gleason and Gina Green-Harris on what the University of Wisconsin is doing to achieve health equity by striving to eliminate health disparities. Dr. Gleason is a clinical neuropsychologist who focuses on the care of geriatrics patients with memory disorders. Her specialties include comprehensive geriatric assessments and memory assessments and differential diagnosis of dementia. She's a faculty member of the Division of Geriatrics and Gerontology within the Department of Medicine and is an affiliate faculty member in the Department of Rehabilitation Psychology and Special Education at the University of Wisconsin-Madison. She is a member of the Department of Medicine Research Committee, leads the inclusion of underrepresented groups core at the Wisconsin Alzheimer's Disease Research Center, serves on the board of directors for the Alzheimer's and Dementia Alliance of Wisconsin, and is a member of the scientific program committee for the Alzheimer's Association International Conference. In 2018, Dr. Gleason received a Veterans Administration Strategic Priority Team Award for her leadership in establishing the first dementia-friendly VA hospital in the U.S. Dr. Gleason is nationally renowned for her research in health disparity and preclinical biomarkers of Alzheimer's disease in African Americans and Native Americans at risk for dementia. She's on her way to establishing 2 of the largest cohorts of participants from African American and Native American communities that will support multiple studies at UW focused on examining how Alzheimer's disease differs between various races and ethnicities. Gina Green-Harris is the director of the Wisconsin Alzheimer's Institute Regional Milwaukee office, an outreach center that provides culturally tailored programs and services to the Milwaukee area African American community. The center also provides resources to medical school faculty and staff in their efforts to achieve health equity for all Wisconsin residents. She's also been named director of the Center for Community Engagement and Health Partnerships, which is an outreach program at the UW School of Medicine and Public Health, also based in Milwaukee. Gina has built key relationships within the medical school and with community partners. These vital relationships have led to the development of innovative programs, enhanced services, and increased research opportunities for underserved and underrepresented populations in Milwaukee and southeastern Wisconsin. Presenting Carrie Gleason and Gina Green-Harris.
Thanks so much, Matt. Appreciate the introduction, and maybe that explains why I feel so busy some days. So my presentation tonight is to lay the groundwork to maybe convince some of the audience members about why equitable inclusion is important for the broader community as well as for for all Wisconsin citizens. So if you could go to the next slide, please. I want to start out with a thank you first to the team. And next slide, please. And actually, even since this slide was made, we have 2 new members joined our team, Mr. James Bester and LaTanya Floyd. But this really is an effort of a teamwork effort and a labor of love. My partners in this are dedicated to the principles of health equity. So I appreciate all the work that supports some of what I'll present today. Next slide, please. So reason number 1, for those of you who are motivated by the ethical principle of justice, Americans, as a rule, Americans value justice. It's much of what our country was founded on. So equitable distribution of the benefits and burdens in our society. So research, it turns out, is a resource, and fair distribution of that resource, that scarce resource, should be just. There's competing needs oftentimes in societies, but we've always valued, again, the justice principle, and that rights and obligations are should be equally distributed amongst the population. So this is the preamble to the U.S. Constitution. For those who are constitutional scholars, will recognize that this is a principle on which our country was founded. So next slide, please. So how justice factors in here. These are data from a study from 2016 that highlight that there are groups who are more affected by this disease than other groups. In particular, Native Americans and African Americans, those are the yellow and the gray bars in this graph. In almost every age group, those 2 racialized groups are the number 1 groups in terms of prevalence or incidence, of dementia. So it is a situation where we have a group who is most likely to bear the burden of the disease, but less likely to participate in research, and therefore may be less likely to benefit from our treatments and our efforts to cure this disease. Next slide, please. So reason number 2, a cost for one is a cost for all. Healthcare is a limited resource, and if it's not equitably distributed, prevention strategies in particular, there will be an effect for all in terms of healthcare costs. These are just a couple of studies. One from the Harvard Business Review in particular estimates that there's a substantial annual economic cost associated by ignoring health disparities in our healthcare system. Next slide, please. Equitable inclusion makes for better science. And this is the reason that is closest to my heart in terms of reasons why we should be doing this. Obviously, justice and cost is a factor, but also that we'll do better science. And if we do better science, we'll have more effective treatments. And anytime we are moving from a sort of unique or rarefied group of individuals, trying to move a treatment that worked with them out to the greater population, there's always going to be challenges. So the more equitable we are in inclusion for our research efforts, the more likely we're going to be developing treatments that are effective for everyone. So I'll show you, if you can bear with my science nerdiness here for the next few slides. We'll go to the next slide, please. So these are some data we presented that highlight a really important phenomenon in research. Alzheimer's disease research is done at centers of excellence, and these centers of excellence are oftentimes located in university systems. So if we look at who actually gets enrolled in science, if you look at the map of the US up in the corner there, you'll see that there are states that are a dark blue that represent states that have centers, including the one here in Madison, as well as the lighter blue that are in expansion programs. And you'll notice that it's located for a large part on the coast. And what happens is if we're enrolling at academic medical centers, the pool gets ever more narrow as you move from those who are enrolled at an academic medical center, those who get diagnosed, those who are actually approached for research, who agree to research, avoid a screen fail, which means simply, did they actually make it into the clinical trial, or did they get excluded because of complications or comorbidities or other medication factors? You end up that very small circle in the midst of all of those other circles, those who actually participate in research or get enrolled in research. So we have a problem where we're trying to take what we learned from that very small circle and apply it to this larger circle. And for those who are studied epidemiology, this is always going to be a problem in terms of the quality of our science. And how does this manifest? So next slide, please. Oh, thank you. This makes the point. If you ask if a treatment will work with this small subset, does it work with the population, the larger population, and importantly, will it also be safe? Next slide, please. So how do we accomplish equitable inclusion? If we approach this as a one-size-fits-all bikes are equal. We have all the bikes the same. No matter who we recruit at our academic medical center, the top panel of this graphic shows that that's equality, where everybody gets the same bicycle. Obviously, that same bicycle doesn't work for all. Whereas if we meet people where they are, I'm quoting Gina Green-Harris there, we notice that you adapt the bicycle to fit the group you are recruiting or the individuals that we are recruiting. So how do we actually manifest this? Next slide, please. Through a community engaged research program, what we do is we go to communities who are traditionally underrepresented in research, and we first give either in the form of with our ONIDA partners, with education, with our Black Leaders for Brain Health, we organize events, and then in phase 2, we build advocacy. There, in almost any community you go into, the disease is common enough where you have advocates who say, I've been affected by this disease. You hire people on these projects, and then you end up with a engaged research program that the individuals who are partnering to create research practices feel comfortable participating in research. So with that, we've had success. So next slide, please. So here's some examples of our community engaged research efforts. We are involved in, we have exercise classes, we've sent gift boxes, even during the pandemic, we are engaged in outreach. Next slide, please. So, and this translates to recruitment success. And this is my partner in these efforts, Dr. Fabu Carter, who has just gone to town in terms of her research, programmatic research approach, which has been really emphasizing community needs, especially during the pandemic, really pivoting to address things that were front and center for people during the pandemic. Next slide, please. So to summarize, we have reasons why we prioritize equitable inclusion. Again, I've laid out the case. You may or may not be convinced by some of these points, but I will make for the point that those who are convinced about the importance of equitable inclusion, that these federal dollars that we obtain from our research grants are rarely can we use those to fund the efforts that we have that we're making in the community. Yet they're mandated by our funders, and we're succeeding. It's just been we are actually becoming recognized as a center who has been successful at recruiting groups who are traditionally underrepresented in research. So they're happy with our work. We're continuing to do it, and we are again. I like to say that it's the underrepresented groups in our community who will be key in helping us develop more effective treatments. So with that, I will close and turn things over to my partner, Ms. Gina Green-Harris.
Thank you so much, Carrie, Dr. Gleason. I appreciate that segue into my discussion, which is going to be talking about how philanthropy, quite frankly, has been able to support what Carrie has just talked about, building equitable programs that are furthering our advancing research. And so at the heart of our Wisconsin Alzheimer's Institute Regional Milwaukee office, we are exemplifying the model that empowers Milwaukee and southeastern Wisconsin communities of color, and primarily our African-American communities, but other communities as well, in providing culturally specific healthcare services, for our populations that actually lead to service delivery models that then lead to research. And I'll talk a little bit about our 5 pillars and how they work. Next slide, please. So wanted to share with you just the power of philanthropy. As Dr. Gleason said, oftentimes the NIH or National Institute of Health or National Institute of Aging resources, dollars, are not able to really help us with our community engagement needs in order to address the lower numbers of people of color involved in our research. So we've got 5 pillars where philanthropy has helped us: with outreach, community education, and professional education as well, which I'll talk about, service, advocacy, and research. Next slide, please. So I'll start talking about community engagement. As Carrie said, our motto really is meet the people where we are. And we also follow the Wisconsin idea to the belief that everyone in our state should be able to access program service delivery models, as well as be involved in research. And so we foster that by meeting people where they are. We really provide service delivery and care and community engagement programs that are encouraging our community members to understand research, and particularly Alzheimer's research in this case, at a much better level. So we are out to dispel myths. We increase public awareness and understanding of health disparities and dementia. We reduce stigma and increase diagnosis to improve access and care for those people from diverse communities and adverse communities to get into care for Alzheimer's disease. And of course, we definitely increase the education about risk factors associated with Alzheimer's disease and the awareness of how Alzheimer's disease and chronic illnesses actually go together. Next slide, please. We also provide community and professional education. Quite frankly, what we've learned on this journey is that it is important to have research information go out to community partners as well as to our stakeholders, but also it needs to be in tandem with our healthcare professionals. And so we provide important educational opportunities for our providers in the professional community by way of talking about health disparities research. We also talk about equity and inclusion, and we also try to get our professionals to understand the importance of diversity, equity, and inclusion in their healthcare systems. So we collaborate with several grassroots organizations to do that, to bring that to the intentions of healthcare while we're building these collaborative relationships. And so what you see in front of you is that we also have an annual presentation called Addressing Dementia and Communities of Color, signifies a signature name called Breaking the Silence. And we invite these keynote speakers from across the country to come and educate us on what's new, what's cutting edge, but how do we address dementia specifically in communities of color? Next slide, please. We have a very huge component, again, keeping in mind that service delivery in some of our most impacted communities is critical to making sure that we are connecting the dots and building these collaborative relationships between our neighbors, between our community partners, and our healthcare systems. And so what we've been able to create is this access to comprehensive care by reducing the barriers that impede access and services by building trust, credibility, and partnerships. And the way we do that is by providing culturally sensitive programs that improve the quality of care for persons who are on the dementia journey, as well as their caretakers. And we've been able to do so by having a staff person who actually goes into homes to identify family members who are from diverse communities, and particularly marginalized communities that are in critical need of care and supportive services to, first of all, get a diagnosis and then have a great care continuum in order to build their opportunities to stay home safer and longer with dementia. So another piece of our service model is the give back. We really wanted to create programs that were culturally inclusive and culturally tailored. And what you see in front of you is a model of our care program, the Amazing Grace Chorus, which not only provides opportunities for families and caregivers to sing together, but it's a wraparound service for our family members who are in need, that we have a one-stop service where we provide that for them. All of this is done through philanthropy dollars. Next slide. And I should also mention that all of this is done at no cost to our families. The other thing that we've been able to do through our work is create what we've called the Community Advisory Board. This Community Advisory Board has been an amazing resource for the entire community, and not just the Black community, but the entire community. This advisory board has been instrumental in actually helping investigators on our UW campus, as well as other campuses across the state, understand better how to create research programs that are culturally inclusive, asset-based, and really focus on resilience models for underrepresented groups. I will also say this Community Advisory Board has been instrumental in helping us to increase the number of people of color, particularly African American, who are interested and who are able to enroll in our research study programs, particularly the RAP study in this case. But we didn't stop there. This group also has been able to be instrumental in helping address the lack of diverse scientists and other staff that are to lead this work for research in African American communities. So we have been able to build this new level of infrastructure around the community voice to help support the need for improving research opportunities for our communities of color. Next slide. And of course, research, which has already been brought up. Through our work, we have been a catalyst, as Dr. Gleason has said, to bring community to the table. And since we started in 2008 with our Milwaukee regional office, we've been able to help increase the number of African Americans to be involved in research. Today, when we started our initiative for Milwaukee in 2008, there was less than 2% of minorities, in particular African Americans, involved in the RAP research study. Since we've been in place, we've been able to increase that number to 12% or more. And so we are excited that because of what we've done, taking on this approach of asset-based community development, taking on the approach of meeting people where they are, and really talking about the importance of how we recruit, how we retain people, not just by asking them to enroll, but to providing them services, care delivery models, and really making sure that they are a part of all in which we do and have a strong voice has really been has been instrumental, I'll say, in developing our strategy and allowing us to increase our number of diverse folks in research, as Dr. Gleason said, which is going to be critical to us moving forward for years to come. Next slide. I think I'm going to talk about a few highlights of what we've been able to do during COVID. We've talked about our need to continue to reach the communities. We've moved to a virtual experience. Thank God it's been live, so we didn't have to worry about recordings that we had to do today. But we have been able to really focus our efforts on still meeting people where they are. We've had 16 members of our course and caregivers receive services. We've had caregiver events to make sure that our caregivers are home safely and are getting respite as needed. And we started a coffee and chat series to really continue to engage these communities so that the research can continue, but more importantly, so that we can keep those folks home safe and really make sure that they're getting their needs met throughout this ordeal. Next slide. And so we also started based on the issues, as we know, there's been just this civil disruption in our communities, and we know that racism has played a critical role in our health and other activities, as well as just our whole communities have taken on this new concern about addressing systemic racism. And so we created a webinar series to do just that, bringing credible sources so that our allies can have a way in which they can help us address health inequities through understanding what some of those racial tensions and racial disparities are. Next slide. Thank you and so I will end there and go back to the host of the show. Thank you so much for your time.
All right, Carrie, Gina, thank you very much for your presentation and for all the work you're doing. And Gina, I'm like you, live beats live on tape anytime. Live is the way to go. Our closing speakers are Dr. Sanjay Astana and Dr. Nathaniel Chin, and they will share what the University of Wisconsin is doing to advance and provide exceptional patient care. Dr. Sanjay Astana is the inaugural director of the Wisconsin Alzheimer's Disease Research Center and an internationally renowned researcher and leader in the field of Alzheimer's disease. In addition to his work as director, Dr. Astana holds myriad leadership positions at the University of Wisconsin, including Associate Dean for Gerontology, Director of the Geriatric Research, Education, and Clinical Center at the William S. Middleton Memorial Veterans Hospital, and Director of the NIH-funded Biology of Aging and Age-Related Diseases Training Grant. Dr. Astana sees patients in the UW Health Memory Assessment Clinic, specializing in assessing and diagnosing patients with Alzheimer's disease and related dementias. Dr. Nathaniel Chin is an assistant professor in the UW Department of Medicine's Division of Geriatrics and Gerontology. As a geriatrician, he treats patients at the UW Health Memory Clinics and oversees the clinical care of research participants in Alzheimer's disease studies on campus. In addition, Dr. Chin collaborates with many Alzheimer's disease researchers on campus and is the host of the Dementia Matters podcast, produced by the Wisconsin Alzheimer's Disease Research Center. Dr. Astana, Dr. Chin, it's all yours.
Thank you, Matt. You can go to the next slide. So I would like to tell a story about Sarah. Sarah is a 68-year-old woman, wonderful person, who comes to the memory clinic reluctantly, nervous because of what could be found at our clinic. Now, she feels her memory is okay, but she does get upset at the difficulty she has in finding the right word in a conversation. Now, she's noticed this for some time, but she's brushed it off. Her family, however, more recently has noticed this, and they're concerned. You see, Sarah's mom had Alzheimer's disease, and so Sarah and her family are worried that this could be happening to her. Now, Sarah sees her primary care provider every year for her annual wellness exam, and she denies serious cognitive change. But this year, her husband and daughter come with her for support and also to provide some of that additional information. They feel that her changes are more significant. So the primary care provider does the right thing and gets a screening test, and the scores are low. So a referral was made for more thorough testing. Now, Sarah's story, unfortunately, is not unusual. Next slide. Now, our memory program takes cognitive testing very seriously because we know that it is stressful. It is meant to be stressful. You see, we push the brain to see how it performs so that we can identify areas of impairment, areas of weakness, but also areas of strength. So it's not something we just do to do, and so we have to be careful about doing it on the right people. We don't want to test individuals this thoroughly if there's already significant impairment that could be detected on a shorter test. So we do what's called a phone-based cognitive screen called the TICS-M. Now, this is a very well-known research tool, but we've incorporated it into the clinic. Now, Sarah did this test, and she scored above the threshold, meaning she should undergo more thorough testing. Next slide. Now, had Sarah tested poorly and her history that she provides and her family, if it was consistent with someone who had dementia, she would have gone to a different clinic. Now, this clinic, which is unique to our center, addresses diagnoses, family concerns, and care planning, all without the 1-hour battery of cognitive testing. Now, because of COVID, it has gone asynchronous, which is a phrase that we use a lot in the memory clinic, as well as all clinics, really, where our social worker is contacting and talking to patients and families ahead of time before they see a physician. This shortens the time in clinic, but it doesn't shorten the time with the physician. It's the same amount of time so that we can address all the issues that need to be discussed. Now, Sarah will cover many of the issues that we would discuss in this MGAC clinic, but just not yet. Next slide. Instead, Sarah's going to go to what we call the memory assessment clinic. Now, this is a traditional 2.5 to 3 hour clinic visit, and I didn't misspeak there. That's about 3 hours, and it includes cognitive testing, family meetings with the social worker, and a visit with the physician. It's long, but it's comprehensive, and the patient will leave the clinic with some form of a diagnosis. A key part of this clinic is a 20 to 30-minute consensus conference where everyone on this interdisciplinary team shares the information they've learned as well as their clinical impressions. It's really a critical time in this diagnostic process, But unfortunately, during this period, the patient and family are waiting. Now, most don't mind the wait, but it is a gap that we wanted to address. So we've incorporated selected clinical researchers into our space to conduct some of their important person-facing studies. Currently, we're working with two incredible researchers, Dr. Kim Miller and Dr. Lindsay Clark. Now, Dr. Miller is working on language and changes in language as an early indicator of cognitive decline. And in return for doing this study, she wants to give back to our patients, or in this regard, her participants, and offer clinical pearls on advice of ways to address word finding or potentially memory change. Dr. Clark is developing and implementing new ways of assessing cognitive change outside of this traditional clinic model. And so she'll be looking at smartphone applications and virtual cognitive testing. Now, for Sarah, she would have benefited from seeing Dr. Miller's team, and she would have likely been referred to our Alzheimer's Disease Research Center for enrolling in more research. Next slide. And for our patients, it's not just about the diagnosis and developing a care plan. It's really following through on that care plan. So we have a chronic care management model that tries to do more than adjust medications and check labs. Now, I created this Pathways Clinic to address future issues as well as current ones, so that patients and families are prepared, but that they are supported every step of the way. We've incorporated our wonderful nurse practitioners into this model so that we can gain access and expand to reach more of our patients. Sarah is currently going through this clinic with us. So we are addressing current issues, future issues, family issues, safety issues, and we're trying to develop proactive ways to stay active, functional, independent, and in the end, maintain the best quality of life that is possible for any one of us. We got here because research showed us what was needed. Our patients told us what was needed, and we had the support from UW to meet those needs. But more needs to be done, which is why we push on and we evolve. Now, Dr. Astana is going to talk about ways in which we're doing just that. Next slide.
Thank you, Dr. Chin. So you heard from Dr. Chin how we perform state-of-the-art evaluation on patients who are referred to our clinic, and they go through a real process. And at the end of the day, the team works together to make the right diagnosis for the patient. One of the very unique characteristics of our patient care here at UW Health is that we translate the findings from our research studies and use them to improve care of people who are referred to our clinics with dementia and other cognitive problems. So you heard from Dr. Johnson and Dr. Carlson that we have access to state-of-the-art brain imaging, the PET scans that can detect amyloid protein and tau protein in people. So in fact, some of the research studies that are included in our clinical programs include patients agreeing to PET brain scans to detect amyloid and tau protein. We also, through Dr. Clark, that Dr. Chin mentioned, are conducting some studies where we could do cognitive testing through smartphones. And the advantage of that is that you can do the testing in your own home environment. You don't have to come to the clinic, which really just is a stressful environment for many of us. So we could actually do these testings through a smartphone while you're in your home, in your own surroundings. And Dr. Clark is trying to evaluate how effective these tests would be if we used a smartphone. Another studies we are doing, other studies are how we can improve access to clinical care in our clinic, and also how we can improve entry of participants, especially diverse participants, into our research studies. And these studies we are hoping will reveal some very cutting-edge results to improve care and also increase the enrollment of participants in our research studies, especially those who are from underrepresented groups. Next slide, please. So one of the ways we really have improved care of people who are referred to a clinic is through a model that Dr. Amy Kind developed. It's known as C-TRACK. C-TRACK stands for Coordinated Transitional Care. What Dr. Kind has shown that when people with memory problems get admitted to the hospital and once they're taken care of in the hospital and discharged home, In their home settings, because they have memory problems, they forget to take their medications. They don't drink enough water. They get dehydrated. So that short period right after discharge, while the person is living in their home, is a very vulnerable period. And that is the period where we need some close monitoring. So what Dr. Kine and a group have shown, that once the patient is home, especially someone who lives alone with memory problems, we give them daily phone calls. A nurse calls them every day, and they check on the patient. They want to make sure that the patient is taking their medications, that they're drinking enough water, keeping hydrated, and also they're having a good sleep and maintain nutrition. Just these simple phone calls can be very helpful to the patient. And we can actually, through these calls, find out if any patient is not doing well and bring them earlier to the hospital to prevent any further decline. We have also created a registry where anyone who's interested in research but may not qualify for any active study, they can give some information to a registry, and then we get in touch with them later on when an appropriate study becomes available for them. During the COVID-19 pandemic, we actually have been able to provide care to people through telemedicine. So we have some research ongoing, what might be the best kind of people whom we can take care of through telemedicine. This has been extremely successful, and we have been able to continue providing care to people who live in remote areas. They could not come to the hospital because they had diseases that would increase the risk for COVID-19, or they were not yet vaccinated. So we have a lot of research going on to see what's the best way to increase access to our clinical care and to our research studies using telemedicine. We are also holding virtual memory clinics in remote parts of Wisconsin, and they have been very, very productive. And also we have a researcher, Dr. Nicole Puglia, who is looking into how we can improve swallowing problems that people with dementia have. It is very well known that as dementia advances, majority of people, or most of the people, will have swallowing problems, and that results in pneumonias. And in fact, aspiration pneumonia is one of the leading causes of death in people who have dementia. So Dr. Puglia and her team is trying to find the best way we can manage swallowing problems, also known as dysphagia, and people with advanced dementia. And this is a very unique program, one of a kind in the country, that is doing research right here at UW Health. Next slide, please. So I wanted to just share with you how philanthropic support and donations from you all have already helped us really conduct some cutting-edge, high-risk projects for which it is sometimes difficult to get federal funding. And these funds, your donations, have helped us diagnose the disease early through the PET brain scan that we talked about. It is also helping us to launch the blood-based research biomarker program that Dr. Carlson mentioned. In fact, through some of the dollars we received through donations, we are about to buy a machine here at UW Health that will help us assay some of the proteins, the amyloid and tau proteins in blood, and also help us conduct cutting-edge research in blood-based biomarkers. We are also training the next generation of geriatricians and dementia researchers here through some of the donation dollars that we get. And as Dr. Gleason and Ms. Gina Green Harris mentioned, it is critical that we improve and increase health disparity research. So some of the funds we have received through donation, actually we are using them to enhance health disparity research. And finally, community-based research. We're able to, with those funds, go to the communities, perform all kinds of events so that we can teach people about dementia, about Alzheimer's disease, and also invite them to be a part of the research program here. Next slide, please. I think this is the last slide. I just wanted to, once again, underscore the message that we not only provide state-of-the-art care to people with dementia, but also bring in research findings to improve the care of people who are referred to our clinics. Thank you.
Thank you so much, Sanjay and Nate. Appreciate your presentation very much here tonight. Tonight, we've had the opportunity to hear about cutting-edge research, progress in achieving health equity, and advances in patient care being done right here in Wisconsin from experts in Alzheimer's disease. Please consider joining me as a memorable friend through a donation to the UW Initiative to End Alzheimer's. Memorable Friends is a community of people who support Alzheimer's disease research at UW-Madison. When you become a memorable friend, you support care, education, and future treatments for your friends, your neighbors, and your family. Together, we can improve lives and build a future without Alzheimer's disease. To learn more, please visit memoriesmatteruw.org. And if you'll allow me, at the very beginning of this presentation tonight, I mentioned that I'm part of the Board of Visitors. My wife and I, it's a very personal issue with me. I lost my mother to Alzheimer's 4 years ago, and I would imagine many of you who are with us are here, maybe here for reasons very similar. One thing that we have found out, my wife and I, even if before it hit our family, we didn't have to go far to find someone who was affected by this. So I think for probably everybody on this, within this session tonight, this is a very personal battle, and we appreciate your consideration. Again, memoriesmatteruw.org. We do have a little bit of time here. Our final segment will be our panel discussion. You've had the opportunity to submit questions, and they are excellent questions. We'll get to as many as we can given the time constraints here. So let us get started. And I think this first one, Dr. Astana, maybe one for you here. The question is Alzheimer's disease hereditary? And if you have a family history of Alzheimer's disease, at what age should you get a memory evaluation?
Yeah, thank you, Matt. That's a very important question. So in terms of hereditary, yes, there are some people with Alzheimer's disease who actually get the disease because they have inherited a defective gene. And that form of Alzheimer's is called familial Alzheimer's disease, and is only seen in about 5% of people who have the diagnosis of Alzheimer's disease. Majority of people with Alzheimer's will have so-called sporadic Alzheimer's disease, where they may not have a very strong family history, but they have the disease. And usually the sporadic disease affects people in their 70s and later. The familial form, unfortunately, affects people at a much earlier age, in their 40s and 50s. And the familial form of the disease is a bit more aggressive. It may progress more rapidly. But in general, the sporadic form is common. Although we have one gene called ApoE gene that you all have heard many, many times, that can increase the risk for sporadic Alzheimer's disease. But the genes that are linked with familial form, if someone has one copy of the disease, the odds of getting the disease is exceedingly high. So in general, yes, family history is important, but fortunately, the aggressive form of the disease, the familial form, is rare and only seen in 5% of people.
Okay, thank you for the question. And kind of along those lines, for you, Dr. Gleason, how early can Alzheimer's disease actually be detected?
Yes, I'm sure many of us here are thinking about their own personal risk, right? And want to know how soon they should start screening for this. In terms of clinical, I'll answer this question. It depends on what you're asking about. Detecting the clinical symptoms, you can detect very early in a stage called mild cognitive impairment, when the person's still relatively doing well in life, day-to-day tasks. However, they begin to have some cognitive symptoms. That certainly can be detected in the clinical setting. You've heard a number of tests that we're talking about that suggest that the amyloid and tau proteins are evident in the brain, maybe even 20 to 25 years before you see clinical symptoms. Those are really in the beginning stages. They're in the research category. So it's not necessarily something you would go to your doctor while you do not have symptoms and ask for a brain scan for tau or amyloid. So certainly our tools are helping us to detect this earlier, but I would say that our best detection tools are those that are used within the context of some early memory changes. So memory or other types of cognitive changes. Thank you for that question.
Thank you. That's what she said. Thank you very much for that question. Dr. Carlson, and again, forgive me if I butcher the name of the drug here. What is aducanumab and how does it work? And are there other promising drugs being tested right now?
That's a great question. So aducanumab, and a lot of these drugs have MAB at the end, or MAB, because it's a monoclonal antibody. So that kind of gives you a clue that's an antibody treatment. And what it does is it targets that amyloid buildup in the brain and tries to break it up and clear it out. So it's a drug through the veins that you have to receive the various studies, but every 2 to 4 weeks. Aducanumab itself, someone asked whether it's on formulary. It's still controversial and is not on formulary in a lot of places, including UW Hospital and the VA hospital where I practice with Dr. Gleason. And again, part of it's because the studies showed that it did clear amyloid very well, but the studies weren't as convincing that it really helped someone in their memory and thinking. And so most of these studies will look at both what happens in the brain and what happens in the person, which is really what we care about. So there are a lot of other therapies that are being studied. We are doing several different of the MAB therapies here at UW. We're looking at solanezumab, lecanemab, and there are a variety of other ones there. So we do have resources, and we are actually recruiting for people who are interested in these types of studies now, and you can look for that on our website on the adrc.wis.edu website.
Thank you very much for the question. Here's another one, Dr. Chin, I'll steer this one your way. Can you provide some practical suggestions for how, as a friend, I can best support my friends, one of whom has Alzheimer's, and especially her husband as a main caregiver?
That is a wonderful question, and I'm glad the person asked it. My answer to you is show up. One of the most difficult things that can happen to a family that is someone is living with Alzheimer's disease or dementia, is that people stop coming by, people stop visiting, people stop calling. And that isolation is really detrimental to the person living with dementia and the caregiver and the family. And it's a very difficult dance to have, but you want to offer help. You want to reach out, offer your support, or be a sounding board just so that the caregiver can have someone to talk to. But certainly, as the disease progresses, you could be helpful in spending time with the person living with that change and being that anchor for the people, for the family, in being that framework and support. So that would be my suggestion. Reading up about it, talking about it openly with other people, really trying to take the stigma away from cognitive change. Those would be two of the key things I think we all could do for those that we know and for those that we may know in the future.
Appreciate that question. Dr. Chin, I think we'll keep with you with this next one as well. What lifestyle changes can I make to decrease my odds of an Alzheimer's disease diagnosis?
This is my favorite question, so thank you to whoever asked that. There's a lot that we can do. There's a lot more power in our hands than people have given credit. And what Dr. Astana said about our genes, we are not always our genes. There's something called epigenetics and neuroplasticity. Our brain is an amazing organ. And so certain things have been shown so far to be the most beneficial. Physical activity, aerobic cardiovascular activity has been shown countless times to be something very beneficial for our brain as well as our heart. And it's not just blood flow, there's more mechanisms to it. So I would encourage all of us to get as much physical activity as we can tolerate within reason. The other thing, sleep is an important thing for us, and it's very underrated in our culture, and we need to address that. We all need good restorative sleep. We need to eat healthy food. We need to be with people, unless you don't prefer that. But in general, we want to be with people and socialize. We want to keep our brains active and challenge and learn throughout our lives. And then to acknowledge stress. Stress is real. We've all been experiencing it over this pandemic. Acknowledge it, and then try to find ways that relieve it. And there is no perfect solution to that, but being aware of it and then being able to do something is very empowering. Also have your hearing and your vision checked.
Thank you, Dr. Chin. And again, thank you very much for the question. The next one we'll send your way, Dr. Johnson. Someone is asking, a while back, I read or heard someone was close to having a blood test for Alzheimer's disease. If so, where are we with that research?
It's a great question. The blood tests are highly promising. There's one right now that works for the dementia stage of Alzheimer's disease, and it may work okay in the mild cognitive impairment stage of Alzheimer's disease. It's reasonably accurate at detecting amyloid in the blood, and it's called C2N, the number, or the letter C, the number 2, and the letter N. and you can Google them, and you can also talk to your doctor about that. We're getting ready to be able to offer that to our patients here in our clinics here at UW-Madison. That's the main test that's approved right now for Alzheimer's disease in the blood. And there are several others that are in the pipeline. They do well at the dementia stage, and they're getting better at the stages where there's fewer symptoms and where a person might be earlier in this disease course. And we're excited about the possibility that these blood tests may detect symptoms before, or detect the disease before the symptoms occur. We're not there yet, but maybe in the near future we could be there.
Thank you very much for your question. The next question, I believe for you, Dr. Gleason, is mild cognitive impairment connected to Alzheimer's disease, and do you study individuals with this condition?
I'll answer the second part of that question. Absolutely. It's a really important phase that a person presents with a mild cognitive impairment when they have some kind of cognitive deficit. But as I mentioned earlier, they're still doing well in day-to-day tasks. So really important group of individuals to include in research, because we can learn as much from knowing what keeps a person from progressing as we can from what causes individuals to progress. So it is in some cases connected to Alzheimer's disease. If the cause of their mild cognitive impairment is Alzheimer's disease, if they develop dementia, they will have an Alzheimer's disease dementia, most likely. So they are connected, and they are a very important group to study, to include in our studies, I'll put it that way.
All right. Thank you very much, and thank you for that question. Up next, we'll go back to you, Dr. Johnson here, I believe. This question comes to us from a RAP participant, and this person would like to know the status of the RAP study, particularly the impact of COVID-19 and any potential changes in the study design, time frame, statistical outcomes, etc.
I want to thank you for being in the RAP study, whoever asked that question. Our participants are so dedicated, and similarly, our participants in the Alzheimer's Disease Research Center Clinical Core, highly dedicated individuals. Thank you all for making research happen. We couldn't do it without you. And so the RAP study is thriving. We are doing research visits. We're running PET scans. We're collecting blood for these blood-based biomarkers. We are asking people to volunteer to provide spinal fluid so we can determine what proteins we can see that might be happening in the brain. We're running cognitive visits as well. Some of the stuff that I tried to show earlier tonight about when this disease starts has been possible because of a decade of research in RAP with these amyloid PET scans. So it's going extraordinarily well. And similarly, our Alzheimer's Research Center is running visits. We're nearly up to full speed with our program, and we thank you for your patience during COVID. We still want to run these visits in a safe way for you, and so there'll be extra precautions when you come in for research visits, and we will work with you on those precautions and advise you on the visits as we schedule those with you. So thank you for those who are research participants in either of these studies. We certainly couldn't do it without you. Here's a link to RAP. I'll put that in the chat. You can see some of our papers there.
Good. Thank you very much. Let's get to our next question. Gina, we're going to circle back to your presentation for this next one. A person wants to know, why is addressing health disparities important for Wisconsin?
Sure. It's a great question. Thank you for asking it. It's interesting because we know that Alzheimer's disease really is a major public health crisis in our country, and particularly for our communities of color. African Americans are 2 times more likely to be diagnosed with some form of dementia, whereas our Latinx community and Hispanic community is up to 1.5 times more likely. And then, of course, can't leave out our Native American community as well. So our Black and brown populations are significantly impacted by Alzheimer's disease at an alarming rate. And what makes it so alarming is that, again, I think one of the questions that was asked in the chat, it was about population size, and so disproportionately impacted, right? So African Americans make up about 6% or 7% of our state population, yet we know about 13 or so percent of our communities of color, particularly African American, are having Alzheimer's disease, as well as 12% of our Hispanic communities, and we only make up 9% population totals, and it's even worse for our Native American communities. And so we definitely know we need to understand what's going on and why this is the case. And so while we know that our ethnic minorities are disproportionately affected by Alzheimer's disease, we don't quite understand why. We also know that it's not all genetics, right? So why we need to be involved in research is to answer the questions of why, quite frankly. And the only way to do that is to have our communities engaged in research and understanding from our perspective, I think as researchers, understanding how to engage communities, which can lead to better testing, which can then lead to better service delivery models, and then hopefully with the reduction of, folks in our communities getting Alzheimer's disease, because it's also based on comorbid conditions and multiple health chronic illnesses as well. And so we need to start understanding the connectivity between that. So the only way to do that is to have all populations be involved in research.
Thank you, Chi. Yep, thank you. And thank you for that question. I'm going to try to move on here to a couple of more. We are running a little bit short on time, but I want to send this one out either to you, Dr. Johnson, and or you, Dr. Carlson. Are there research studies currently in progress that include people with Down syndrome?
Yes, there certainly are. We are one of the leading sites for a national study. It's called the ABC Down Syndrome Study. It's a consortium, and we're in fact the leading enrolling site in this consortium of sites here at UW-Madison. It's called the ABC DS or Down Syndrome Study. And I did see that question earlier in the chat, and I put a link on our side, and hopefully it got sent across to the other side in the comments.
And again, these studies are extremely important to help us learn more about how these biomarkers and early changes, how quickly they show up in this population of people who are at very high risk of getting Alzheimer's disease. The number of people in the country with Down syndrome is smaller than, obviously, than the general population, but they have very high risk of developing Alzheimer's. So again, this is the first step, but again, hopefully getting more clinical trials where we can see do these therapies work in persons with Down syndrome, so that we can hopefully get some preventive therapies or treatment therapies for this important group of individuals as well.
Okay, next question here. I think we've got time for a couple of more. Dr. Astana, does Aricept medication help improve memory or perhaps postpone Alzheimer's?
Yeah, thank you. Thanks for that very important question. As we all know, that Aricept, also known as donepezil, is one of the FDA-approved treatments for Alzheimer's disease. It's been around for almost 15-20 years, and it's being used extensively worldwide. So the way Aricept does, it certainly improves symptoms in some people with Alzheimer's disease. And there's quite a bit of evidence that even if you may not see an improvement in symptoms, Aricept may delay progression of the disease for a few years. And I think that is important. The only issue with Aricept, it does not affect the disease pathology. So it does improve some of the symptoms. It may delay the progression of cognitive symptoms, but it does not affect the amyloid and the tau protein and other changes that are seen in people with Alzheimer's disease.
Okay, thank you. I believe we've got time for one more, and this is maybe a little bit more all-encompassing. Dr. Carlson or anyone else, if you want to jump in. Question from someone wants to know, how can I help? And are there any opportunities to volunteer for research?
Yeah, one of the greatest joys, I think, of our work is being able to partner with people from across the state and across the country to complete this research. So we have really strong partnerships. Our RAP study is over 1,600 people. Our Alzheimer's Center is over 1,000 participants. So joining our registry, calling in or emailing or going to our website, the adrc.with.gov EDU. I hope I put the right one. Hopefully
That's
she can put that in the chat. But our Alzheimer's Disease Center web is a good memory test for me. But again, we are looking for people for all kinds of studies. So we would love to have diverse participants. For most people age 45 and above, there may be a study for you, whether you have cognitive impairment or not. There are interventional studies where you take a therapy. There's some without that. There are caregiving studies. There are all kinds of possibilities. There's so much work to do to help improve the early detection, treatment, prevention of the disease, and also to help support caregivers and families. So we encourage people to get involved. And I don't know if maybe if I can just add, Ms. Jean Green Harris or Dr. Gleason, someone's asking to have about having a friend, African-American friend who lives in Madison, to be a part of research. You know, what are some things for her to consider? I don't know if you want to comment specifically on that as well.
Carrie, you want to go first, and then I can answer thereafter?
Absolutely. I like to say that our African-American community here in Wisconsin is going to help cure the disease. So absolutely, and if she's had a different experience prior to 2009, I can say that we can do better this time, and I apologize for her past experience. So I do hope that she would consider giving us another try.
Yeah, and I would only add to that, Carrie, I think that's great. You know, one of the things that I encourage people to do who are hesitant to do research is just to come and learn about our programs and be willing to volunteer through our service delivery model. That's the importance, quite frankly, of having that community service model that we have, where we are actually contributing ourselves to the community in a way that we are becoming the fabric work. And so while you may not want to be a part of the community, a part of the research right away, you might want to learn about us and volunteer with us to help us get the word out, learn about us, and let's eat and break bread together. And then let's talk about research later. But I think that's really been critical. And that's some of the repair work, quite frankly, to Carrie's point, that we've been able to do with our communities, particularly our African-American, Latino, and our Native communities.
That's a great suggestion, Gina. She could start by joining our exercise class.
There you go. Yeah.
Very good. Since we're live and we're going to throw away the script, if we missed anything, is anyone else, any other important point that anybody on the panel would like to go ahead and get across now before we conclude the session?
Yeah, Matt, maybe I will just jump in here and please chime in others. You know, I want to really thank all our participants who over years have contributed just precious data to our research studies. And that's the only way we can win a disease like Alzheimer's. There are no shortcuts to medical research. That's the way we won over heart disease, cancer, and many other diseases. And research is the key to understanding and eventually preventing Alzheimer's disease. I want to thank our participants and also want to thank you all for donating and for your philanthropic support to our program. Those are precious funds for us, and they allow us to take plan some high risk, high return projects. So thank you, everyone, for your support.
Absolutely. We thank all of you for joining us here tonight. What a distinguished panel with us tonight. Ms. Gina Green Harris, Dr. Astana, Dr. Gleason, Dr. Johnson, Dr. Carlson, Dr. Chin. Thank you for all the work you are doing, and we very much appreciate your presentation here tonight. And most importantly, we thank all of you for joining us. We thank you so much for your patience. We worked through all that. Live is always better, as Gina said. I could not agree more. So that is all we have tonight. Again, we thank you for joining the Memories Matter live stream and for your great questions for our panel. We hope that you got a lot out of tonight's program and that you'll consider supporting the UW initiative to end Alzheimer's by becoming a memorable friend. And again, that website is memoriesmatteruw.org. We thank you so much for joining us and have a pleasant evening.
Thank you. Bye.